Welcome to episode 6 of the Holistic Human Project. My name is Luke. I am the host and CEO here at AMN Academy. And today we are going to be following on from last episode where we're talking about post-surgical rehabilitation. But before we get started with today's episode, I wanted to offer you the opportunity to get access to some of our education absolutely free. So if you head to our website, that's amnacademy.com. So it's Alpha Mike November, AMN academy.com. There's a free resources link on the website. You can just click on that, and there's a bunch of things that you can pick from. So just pick whichever tickles your fancy. So today, in today's episode, we are going to be talking to Dr. John Campione. Dr. John Campione is a AMN practitioner. He's also a member of the teaching faculty here at AMN Academy. He's also an instructor in the Clinical Sciences Department, teaching courses in functional rehabilitation, ambulatory trauma, and palpation skills at the National University of Health Sciences in Illinois, in the USA. He's a Board Certified Chiropractic Physician. He's a graduate of the National University of Health Sciences, receiving his Doctor of Chiropractic degree back in 2010. Dr. Campione received a Bachelor of Science degree in Exercise Physiology as well, from the West Virginia University School of Medicine. He's also a Board Certified Physiotherapist, bit of an overachiever in Illinois, and has postgraduate certifications in acupuncture, strength and conditioning with the National Strength and Conditioning Association, corrective exercise with the National Academy of Sports Medicine, functional movement systems, neurokinetic therapy, active release techniques, kettlebell training with the World Kettlebell Club, and as I said before, is a practitioner here at AMN Academy as well. So he is an absolute wealth of knowledge, has a very broad spectrum of expertise from physiotherapy, physical therapy, chiropractic, through to physical training, personal training, and the neurology aspect from here at AMN Academy. So we're going to be talking to him today about post-operative rehabilitation, post-operative care. I hope you enjoy today's conversation. Let me know what you think. And without any further ado, we'll get cracking on today's episode.
You guys ready? Go!
The Holistic Human Project.
Oh, well, that's interesting.
Exploring how to be healthy in the 21st century.
Oh, you don't say.
Breaking down cutting-edge science into bite-sized bits.
Just how I like it.
And delivering it to you fresh.
So welcome, John, and everyone knows Dave. So what we're going to basically do today is just kind of follow on from our last podcast episode, which Dave and I talked about specifically my knee injury and the post-surgical rehabilitation. But I wanted to kind of go into a little bit sort of a broader view of all post-surgical rehabilitation, and also maybe just kind of discuss some of the new science around sort of non-surgical interventions for certain things when it's appropriate to, consider surgery, obviously without, stepping on any surgeon's toes, and sort of preface it by saying, always follow the advice of your medical professional and surgeon if you have an injury and you've seen someone and they recommended surgery. But there may be certain instances where it's valid to seek a second opinion or something like that. So just going to talk about that kind of stuff and just, chat, see where it takes us, really. So what the first thing I was going to talk about, basically this whole episode really sort of focus on orthopedic sports injuries primarily. So, cover mostly joint connective tissue injuries. I'm not really going to get into, other surgeries that could require physical therapy as well. Because I just want to kind of keep it relevant to the audience. But I guess we could kick off by sort of looking at like non-surgical versus surgical. For example, I'll give like an example and then we can maybe just kick off from there. And so in the 90s, when I was doing like gymnastics and dance and acrobatics and all that kind of stuff, it was kind of like generally accepted that if you blew an Achilles tendon or if you blew a bicep tendon or you had some kind of rupture-like injury of the connective tissue, you would go and get surgery. It was just kind of the accepted sort of method. It was accepted opinion. But nowadays it's not quite that cut and dry. And for example, when we're looking at like Achilles tendon rupture, for example, which is kind of the most common sports injury, especially in adults. I guess like previously it was kind of considered that, you know, an Achilles tendon rupture, like a complete rupture, would require surgery. But I was in doing research for this episode, I actually found quite a lot of data, quite a lot of research, quite a lot of literature indicating that, you know, in the last couple of years, so it's fairly recent, indicating that non-operative treatment of acute Achilles tendon rupture has pretty comparable results to surgical treatment, and without a lot of the complications that come along with surgery. So obviously the narrative has changed a bit, or quite a bit, in even in some of these were physical therapy papers, and then some of them were surgical papers. And I'll link them in the show notes. But you know, so the narrative's changed quite a bit on that specific injury. What would you know, when would you say you would consider non-surgical, or when would you sort of start to think about a second opinion if you had an injury and you went to see a surgeon, and you know, a surgeon's job is to do surgery, right? So they're going to recommend surgery most of the time. What would be your process if you'd injured yourself, John, and you would kind of making a decision on how you were going to approach the repair, rehabilitation?
It's an interesting question because I think I'm a very gray area person. You know, I think I frustrate a lot of people when I talk about stuff. So I'll just warn you ahead of time, is there's no perfect answer to that. And really nothing is black and white. There are a lot of factors that do need to come into play. A lot of things you have to consider is the athlete, their level of competition. When do they need to get back to sport? Or do they have the time to work on more conservative treatments? For the, you know, average active individual, for someone like me who's less than average active, but I'll still lump myself into that category, I have to consider the extent of the injury. How can I live with day to day, the amount of pain that's being created from that as well too. And a lot of times that does necessitate seeing a professional, which may further lead to the idea of a surgical consult. So typically my first line of action is going to be conservative care. So whether it's an acute injury or even a chronic injury, one of the first things to really do is manage pain, manage swelling for the individual to get them a little bit more comfortable to be able to do more. What you will find when you undertake conservative care, it will start to open up the picture to the idea of whether or not someone can get better from this with therapy interventions, manual interventions, whatever you want to refer to it as, or is it more of a surgical case? And I don't know about you guys in the UK, but in the United States, we do have, you know, a lot of back and forth with the layperson. A lot of times as they have an injury, they instantly go to a certain practitioner, and it might not be the right practitioner to really go to. You know, a medical doctor is not necessarily trained into musculoskeletal care as well as a chiropractor or a PT. They have other specialties is my point. So you get a lot of medical doctors that often in general practice, they will see an injury like this. And one of the first go-tos is, you know, orthopedic consult, a surgical consult. I personally, in my experience, good surgeons know when to not do surgery. And I have to really chalk that up to, I have a good network of people that I can communicate with, and they give me a good idea. Like, I think this person should go through care first, conservative care first, and see what you can do with them. There are other situations where somebody might need to go through some therapy, even prepare them for surgery so that after surgery, they can come back even better. So there's a lot of variables that really come into play with that. The extent of the injury, the severity of it, the acuteness of it all really do come in. But I do, again, personally think that a good surgeon, even if that's, the first line for someone to go to, will know when you want to do that. I say that all the time, just like you said, Luke, is, a surgeon's job is to do surgery, but good surgeons really do understand, this is not a surgical case, or this is the case where I really do want them to go through some therapy, reduce the pain, reduce the swelling. It might actually make surgery more comfortable. And then afterwards, when we have to inevitably rehab that after the surgery, we're going to be in a better spot there too. I'm very conservative when it comes to treatment. You come to me, most of the time, I'm going to try to help you as best I can. So then there's another situation where somebody's just not getting better. I typically, give it a handful of visits. And if I'm seeing decline or no change at all, that's when I start to think, okay, I need to consult with someone for a second opinion. The extent of the injury leads me to say, I would like you to go see this surgeon and see what they say regarding your injury before we move on anymore.
Yeah, right. That's a good point, because in a lot of the research that I read, one of the main issues was compliance in the clients. The people who tried conservative methods, the likelihood of re-rupture and all of that kind of stuff was fairly comparable, but the issues that they faced was obviously low compliance in a lot of people when you start to kind of prescribe, considering that depending on who your clientele is and their available funds and private health insurance and all that kind of stuff, you may only see someone, at most once a week, likely maybe less than that, depending on certain factors. So yeah, it's a good point about, if you don't see a progression, if you see a decline, for various reasons, but compliance is a big issue. I remember reading a study, nutrition study, where they were looking at medication that was required to save people's lives. It was like a heart medication or a blood pressure medication or something like that, and compliance was like 60%. For a type of medication that it's a pill, it's easy, and it's to save your life, and compliance was that low. So physical therapy compliance,
Luke,
yeah.
Real quick with that study, I'm just curious if they said anything, because I've had this discussion with someone before. The compliance that I've seen it when I was talking about it comes a lot of times from refilling prescriptions.
Right.
It's on my nightstand. I can take the pill, but this is empty. I'll call the doc when I get the opportunity. Is that, I don't know if they alluded to that, but that's a good situation, is like, if it's not ever present to a lot of patients, they forget about it. And one thing, the compliance is really important. That comes with therapy. So you get a lot of patients, they're not getting better. One of the first questions is, are you doing what I ask you to do? And this goes along the lines of like, I was brought up in physical therapy when I first started working in healthcare in the early 2000s. I was the tech that was giving people this gigantic novel of exercises. Like I was printing off the pictures, and there's, 5 pages of different exercises with the sets and reps, and saying, here's your stuff. You got to do at home 3 times a day. So people won't do that. So reducing the amount of stuff you give them, like the 1 good exercise or the 2 good drills that they need to do, is really, really important. But also, the idea of whether or not I can actually show them the value in what they're doing is really, really important too. Compliance is really important. And I think when you get into mixing in, because I think you're alluding to like health insurance a little bit there, there's always that component of like, well, we can't get a surgical consult until you do this many visits.
Yeah.
And then sometimes the practitioner is like, I know it's a surgical consult. I know it is. I know, but we have to go through and do all these visits. And it's almost like, I'm almost kind of spinning my wheels until we can actually get this person some kind of help. So I think there's a lot of frustration that comes with that too.
Yeah, absolutely. You touched on kind of helping someone deal with the pain if you're looking at a conservative treatment, reducing inflammation and stuff. I'd like to kind of talk about that a little bit more. Before we do, Dave, I was going to see if you could kind of, we could touch on current of injury and maybe talk about that a little bit, what that means, and how we can incorporate some of that kind of stuff into it as well?
Yeah, sure. I mean, just to kind of caveat what's being said already as well, is that what we're really touching on at the moment is the ultimate best outcomes come from the best individuated care that you can give in any situation, and that there are certain roadblocks to that in certain practices. Sometimes it's impractical in certain practices, but the closer we can always get to that, I think ultimately the better outcomes are going to be, because every single person is going to tolerate things differently, whether it be a rehab program, compliance for a certain exercise, if they're a type of person that's never done exercise, their pain tolerance, their the severity, the suffering, the individual are really the things that make a huge difference. But physiologically speaking, when you get these a laceration of the skin, a rupture of a tendon, damage to physical tissues, there's what's called a current of injury, which occurs, which is basically an alteration to the electrical flow throughout the tissues of the body. And initially, it's a very, very clever response, which by altering the current around where there's an injury on the surface of the body or on the structure and the tissues of the body, it's an alteration to the current and an alteration to the resistance that indicates to the brain that there's something wrong in that area. And then that brain will mobilize what's required to try and deal with it as best it can at that moment in time. This is definitely something that's very true for acute phase injuries. But what we sort of find, and what AMN is particularly based on, is the fact that those current of injuries don't necessarily completely dissipate, and that the current of injury can be present in all bioelectrically active tissues. And it could be something that we need to try and resolve in chronic cases as well as acute cases. It is a very clever activating system, which indicates to the brain and all the metabolism as to where it needs to send resources and send things to resolve the problem. But also one of the ways that we do make big changes in people, especially, I've never really been the acute injury guy, but in terms of the post work and in the chronic work, when we get to reorganize these currents in the body, that you do see a lot of great change, and you can get a lot of reduction in pain. So it's very, very useful process to understand.
Yeah. And so if we can go on then to like talking about inflammation. I think inflammation's, it's critical to talk about inflammation. Obviously there's good inflammation. We want there to be a certain level of swelling. Maybe John, you could touch on why we want, why that is, because I think a lot of people have this kind of a concept of this idea in their head that swelling is bad and I've got to get rid of it as soon as possible. And so we can touch on like inflammation and swelling, management, how best to kind of deal with it, and why we want some level of swelling, just not chronic swelling.
Yeah, swelling, inflammation, however you want to refer to it, is a natural process. So when there is an acute injury, that will happen. And really two basic reasons for that is to bring blood flow into the injured area. All your white blood cells come in there, your neutrophils do their thing and clean stuff up. All the other white blood cells are involved with that. Obviously, platelets come in there for any sort of plugging up of the wound, whatever you want to refer to it as, but basically blood flow to the area to help perfuse that tissue and improve begin the healing process. The second big thing, especially from a neurological perspective, is you get that erythema, you get that swelling in there. It also limits range of motion, and oftentimes is part of that output of pain, because it's telling you don't do anything with this. Yeah. Please leave. It's like when I'm telling my son is like, I need to work on this. I'm putting it here. Don't touch it. Right. Yeah. That's kind of like swelling in your knee when you just tweaked it, is like, can you stop using that for a second while we're doing our work or something like that? So swelling is important. When we start to get into more of like, just start to get out of the acute phase and into the more subacute phase, when swelling persists, then essentially you have what is referred to as edema. And, I apologize for anybody giving them nightmares of your physiology classes, but basically with your circulatory system, you have arteries bringing blood into the tissue. It starts to move down into the capillary level, and that's where the tissue perfusion comes. We metabolize, we dump off oxygen, we pick up all the waste products, then the venous blood flow brings it back out. Well, between the arteries and the veins around that capillary tissue level there's a net overflow of fluid. And what happens when there is even more than that net? Well, first of all, when there's a net overflow, the lymphatic system picks it up. Lymphatic system is another drainage system. It heads all the way back up towards the subclavian vein. So basically it dumps into venous blood flow. So it goes back in the heart. But throughout your lymphatic system, it's a check system to tell you, is there any sort of like disease or pathology or any offending thing in your body that we need to attack? When you have excessive overflow, that edema, oftentimes what it leads to is poor venous insufficiency and lymphatic insufficiency as well too. What will then happen is you get persistent pain, limitation in range of motion with all of that edema. So what you will often find is that a lot of people, they have disruption in lymphatic flow, even venous blood flow as well too. And when you add to that, people often will just stop moving after an acute injury. They're not getting muscle pump for the venous or the lymphatic system because those don't have their own muscular layers to help move it along. That starts to persist a little bit longer. So it's persistent inflammation and persistent edema that is really the biggest problem. And there's a lot of different resources that'll give you different ranges. It's typically, within a few days or so, you should start seeing that start to dissipate a little bit more, start to get that pain decreasing on its own. Chronic injuries, we're talking about acute injuries a lot, but chronic injuries oftentimes are where we start to see problematic inflammation. It's always there. It's bringing on pain. It's limiting joint range of motion. And then we start to get into the discussion of, with all that there, we change the way that we move around the pain and the swelling. So it's extremely important to recognize when it's good and when it's bad. I've had patients come into me, they just hurt themselves, or if I'm sidelining a sport or something like that, they just hurt themselves. I'm not going to go into any sort of manual techniques that helps with that swelling per se. I want to manage the pain, but the swelling is there for a purpose. So my biggest goal is to just make someone as comfortable as they can and let them rest for a day or two. And then I can start to jump in and really get into my manual work. Because a lot of times the manual work will be even more painful. So you start to get into some of the lighter techniques. Then you could start to progress into directly affecting the edema and then even managing the pain a little bit more with some of the different manual techniques that we have.
Cool. And I think like one of the things that I came across, which I found so really surprising, was that, when you do high impact sports, gymnastics, dance, all the kind of stuff that I was into as a kid and a teenager and a young adult, you injure yourself a lot. And most of the time it's fairly minor. It's strains and sprains, but obviously you have when you're at high level, you have physiotherapists, team physiotherapists, and the time old kind of rice technique, rest, ice, compression, and elevation. But I actually, when I was kind of looking into it, I found that there's a contrary kind of view to that, and that's actually quite outdated. And in fact, the doctor who coined the phrase, who came up with that, has come out and said, "I just made it up. Like, there's not really anything to support it." I would like to recant it now, which I find really interesting, because it's still, very prevalent. To the first thing you do when you sprain an ankle is, rest it, put compression bandage on, basically limit the inflammation, limit the swelling, which can then have obviously kind of negative effects as well. And people get quite emotional when you say maybe rest, ice, compression, elevation isn't the best way to be treating this. So what are your kind of thoughts on that?
Well, That's I try not to. Was once one that enjoyed jumping into contentious arguments, um, and then I realized how long that stayed with me. I'm gray area.
Yeah.
I think it helps in certain instances, but because of my neurological education, which started with AMN, you guys really opened me up to understanding the neurology behind everything. I take that approach oftentimes with just about any sort of input. Compression and ice, cold, are all inputs. So what I think the argument is what we were saying rice doesn't actually happen. But I don't think that should completely dismiss it. So ice might be a modulating input for managing pain. Maybe someone likes cold, and it is that input that helps to gate the pain for the time being. So maybe it's not reducing the swelling, because of course we need that swelling again in that acute state, but maybe it's just the cold temperature, that touch is moving through that spinothalamic system, and so does pain, some kind of pain, and maybe that's just gating the pain for that individual. If they want to use it and it makes them feel better, let them use it. And people are going to fight me on that after they hear this. I know that. I'm trying to see all sides of the argument. Compression might also be the same thing. It's an input. Some of us respond really well to compression. Some of us respond really well to decompression. In an acute state, it's hard to really go into that, but compression, light compression, could be very effective. So you could get into, like, lymphatic massage therapists are so good with acute cases, because their pressure, the way that they've always told me, is it's the pressure of a nickel on the skin. And I apologize, you guys are UK citizens, so the pressure of a coin on the skin.
A small coin.
Nickel, and it's like, I don't know what I'm talking about. But it's very light pressure is the point. So it's not going to provoke any kind of pain, but it can actually help to start and manage it. There's a touch perspective there. So there's pain gating that could come on with that, and it could manage that as well too. Again, I'm just trying to see a lot of different sides of the picture, the different perspectives that are there. I take more of the neurological approach. If you feel better when you put ice on it and you wrap it up, and that light compression gives you that kind of like thunderjacking effect, then do it.
Yeah.
Don't do anything that makes it so much worse. But if you have things that are improving it, then go ahead and do that. And I think that's where more research should be done to say, like, okay, if you use ice, can it actually make it worse? And if we start to see research that says when you do that, it actually gets worse, then we start to have the discussion. Okay, let's start to move away from that idea.
Yeah. And I think to touch on that, like I used compression in the knee surgery. Dave's got his hand up. You got your hand. I used compression when I had the knee surgery, after the knee surgery, because I had limited mobility. So I wasn't able to do I had no mobility, so I wasn't able to do the muscular contraction, which would assist the lymphatic system to then drain the joint. So I would be using the compression in conjunction with like the EMS machine, the electrostimulation machine, to contract the muscle, and they also sort of assist with kind of flushing that joint and then allowing it to, obviously re-swell after the stuff. But I'm the same. I think that I'm not personally a huge advocate of ice, because it doesn't really benefit me. I don't find that it really helps in terms of pain and stuff, but as you say, for some people it may, and that's totally fine. But yeah, compression I found to be really helpful, especially with joints that have no mobility at the time, if it's a really severe injury, to help with that inflammation.
Input.
I've got to just jump in with a couple of things there, because I finally have something to say, which is cool. First of all, that thing you said about rice, the fact that, did you say it was a surgeon that threw that out kind of whimsically, and then it kind of stuck in the world?
It was. I don't know if he was a surgeon. Yeah. He was a doctor. He wasn't medical doctor. Yeah.
Yeah. I mean, poor guy.
That's where knees over the toes came from too. Is some orthopedic surgeon just didn't like squatting.
Yeah.
So he started to write about how it's.
And that actually, I remember back in the back in my personal training days of being heavily in strength and conditioning, there was something that was always thrown around a lot, saying, well, you can't do plyometrics until you can squat double body weight. And I think that was something that was said by, it was, I mean, my apologies if this is wrong, but I think it was Mark Verstegen or another, popular, very successful strength coach. And they mentioned it in an interview, and they're like, so where did you find that? He was like, I just made it up. I was put on the spot and I just said it because I had to say something, and it sticks like it. That I heard that a lot in the strength and conditioning circles. I was like, one, I've not met that many people that can squat double body weight. So
yeah,
like,
but they can all jump.
But everyone could jump. Yeah. Yeah. Anyway, that's an aside. But in my other, many years working as a neuro-mystical voodoo practitioner, and working with all kinds of injuries and bits and pieces.
You got to patent that.
And that's now how I'm more mystical by the hour. I remember seeing a lot of things that shouldn't have made any difference and shouldn't have changed anything that did. And I think what you've touched on there, John, is the fact that we have to remain open to, there is specificity to whatever's in front of you, and there's certain inputs that are going to have more impact than others. And I remember seeing things once, a lady I was working with in the gym just had her ankle just started swelling up, and we weren't aware of any particular acute injury. Something had been reignited in her system. I started assessing. I was like, okay, let's start assessing stuff. She started doing some vestibular drills in a seated posture. I think some VOR stuff. I was rubbing on the skin somewhere, and the whole thing, it just went away. The swelling just dissipated in front of our eyes. And I didn't really know why. She had no idea why. But it was kind of a highlighting point of the fact that, there's stuff going on here that we can utilize that is extremely specific to that individual's nervous system. We just have to try and work out how to find it. And of the past kind of 4 to 6 weeks, I've been working with, obviously much longer, working with people remotely online in my sessions. And if there's pain, I'm trying to define, where is the awareness of the pain coming from? Is it a somatosensory awareness? Is it an interoceptive awareness? Or does it go deeper? Does it go into the ARTAS system, which is the ascending reticulothalamic activating system, which is kind of the seat of awareness in the brain? What tracts involved in it? What nerves are involved in it? What receptors are involved in it? And when I kind of map all those things out through the process that we use, and then we calibrate them, which is essentially a tapping modality using piezoelectricity in the body, a lot of the time the awareness dissipates very, very quickly. And I haven't used anything, it's not like I've been pushing on muscles or having them compress or elevate or do anything that may, have some statistical relevance to what they're suffering. It's the fact that we've gone into their nervous system and kind of said, well, what do you need? And trying to give that system what it needs at that moment in time. And that's how I've done things as a voodoo practitioner for many years now. So
like bringing it back to what John said before, it's that individual approach. It's rather than, and this is the issue that I had to be said in the last episode, when I went to see a physical therapist after the knee surgery, it was very clear to me within the second session that I was being given a knee rehab by numbers routine by this guy. There was no adaptation to my specific injury or to my specific presentation. It was very, this is a knee injury, this was knee surgery, this is the program that I follow. So yeah, it's kind of come back full circle to that. If you're a therapist or a trainer and you're kind of listening to this, treat people as individuals. Get as much specific information about that person, about their system, their nervous system. The more information that you can draw from someone, the more tools you have to gather that information, the better you're going to be, the more effective you're going to be as a practitioner, as a therapist.
Absolutely. Yeah. I mean, I say this a lot, and, it can get me in a little bit of trouble, but the diagnosis is the best label we can put on something. There's no diagnosis for Luke or for David or for John. It is, wow, a lot of apostles there. Except for David, right? Old part of my life. Very biblical when I listed all their names. You see the tangents I go off on? Forget what I'm talking about.
We need a Matthew in here somewhere.
Yeah.
You guys want? But you have to treat the individual. Like, this is a very popular idea. I love seeing it more and more. I just want to see it more in practice. It's like, okay, you got XYZ diagnosis. Okay, but I got to see you, and I think this does play a role as a practitioner, whether you're a trainer or a therapist, a doctor. There is conditioning that comes from the patient as well too. Is like, I have this shoulder injury and my friend had the shoulder injury, and this is what their person did for them. And then you don't do exactly that. Patients start to be like, well, what are you doing? And then their psychology gets into it. The biopsychosocial approach comes into play. And then even that can be a component of whether or not they're compliant and or even getting better.
Yeah, that's a really good point. We touched on that in the last one, where we were talking about, like the surgeon. I know it's their job to manage your expectations on what your rehabilitation is going to be like and what your outcome is going to be, etc. And the surgeon told me, you may never walk properly again. You may have a persistent limp for the rest of your life. Blah 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 blah. Based on the kind of surgery that I've performed, based on the injury, based on the statistics and my experience and all that kind of stuff. And that's fine. They have to work with the statistical model, and it's their job to give you the expectations. But that can have a profound effect on somebody's psychology, which can then have a profound effect on their results. If you believe that you are going to have a persistent limp for the rest of your life and you may never fully recover from something, that can become a self-fulfilling prophecy. It's really important to kind of address that. So maybe you could talk about that a little bit.
Yeah, it's funny you said that. I'm reminded of the Benedict Cumberbatch version of Sherlock on BBC. Big fan of that show. And the first season, Martin Freeman plays John Watson. He has a limp coming back from war, and then Sherlock did this elaborate ploy where basically, like, kind of almost like got him into action, and then all of a sudden his limp went away, and basically proving that was all in his head, kind of thing too. Words matter. I'm not disparaging that surgeon. This is just what that surgeon does, but absolutely not saying he said anything wrong to you or anything like that. But maybe the lexicon needs to be changed a little bit. Maybe we need to discuss how we say things or what we say to patients as well too. Instead of saying you may never walk right again, because there's no such thing as perfect gait. There's no such thing as perfect movement, to be perfectly honest with you. As much as we look at it from an assessment perspective, what if he had just said to you, you're not going to walk exactly the same as you used to? Because if I say you're never going to walk right again, you might start to have this biopsychosocial effect where you're constantly in pain, but it's not necessarily a biological pain. Maybe it's driven more by that psychological thought that your doctor told you, this expert told you, you're not going to walk, quote unquote, right again. And you always are thinking about that. Or your doc gave you a prognosis. And again, not in a malicious way, but as you go through therapy, in the back of your mind, it's always, well, my doctor said that I'm probably not going to get to this, or like, this is my limit, or something like that. And we always have exceptions. There are people who are like, doc says I'm not going to walk right after this. Want to bet? And there are people who really get into it and they're like, no, I'm gonna do that. Like, I love seeing those videos of people standing out of their wheelchair because they just wanted to fight it and stuff like that. But I think language is an important thing to talk to our patients about, but that's kind of a, cover your butt situation as well too. That doc can't tell you that you're going to be able to do this, this, or this. He's basing it, like you said, Luke, on statistical information. And I think I'm absolutely behind that. He should be doing that, but I don't think that should veer away from the individual treatment. We should see where we can get you, your top range, or try to move outside of your limits. I think we can always get better. We can always improve. Some of us will plateau for longer, sooner. We might plateau several times, but I think we can always be improving. And I know I say that, and some people are screaming at their phone, whatever they're listening to, and be like, yeah, but what about like age? This happens during age, or this happens during that. That goes back to the individual. We have all these statistics, right? But I'm 38 now. there are plenty of people 10 years older than me who are much stronger, much faster. They look a lot better than me. They have much more hair than I do. What do you say to that? And I know somebody would be like, well, they're outliers. It's like, yes, but that's the point we're trying to make, is if we look at people individually, we don't have to just fit them into that statistical construct, and we can help them on an individual basis. And maybe we can get them outside of that statistic.
Yeah, absolutely. I love that, because it is really important. I talked about it in the last episode, and if anyone hasn't listened to the last episode, they can obviously go back and listen to that one. But we talked about, that I was in a really good headspace prior to the surgery. I practice meditation. Have an amazing network of professionals that I can talk to and get help from. And so I was in a really good place. And when the surgeon kind of said that to me, I was one of those people who's like, yeah, you want to bet? And, I will walk normally again. I will be able to do sport again. I will have, wasn't even a question. I didn't even doubt it for a second. But I think it's a really important point to hammer home, that words matter. And that if you are sort of working with clients and patients, that it is very important to kind of weigh the words that you use while covering your butt, while you don't want to leave yourself liable for any issues, but it is important to factor that in, the words that you use with people.
It's another really good point to reemphasize. I'm not saying that you should tell someone that you can get them to, a place where they've never been before, or, something that is just illogical. That's not my point. My point is to individualize the care, as you're all reiterating. It's very important. And again, words matter. Talking to someone, giving them the idea. I don't think it's inappropriate to be like, well, this is what the statistics will tell us. This is what we typically see. But, if you are working hard enough and doing certain things on a day-to-day basis, you could possibly improve even more than that.
Yeah.
I think it's just giving people options. Like I said for myself, everything's gray, there's always a way. We just have to find it. Yeah.
That's a really good point as well. There is always a way. And it's just about having enough tools, and it's trust as well. It's having the trust of your patient to be able to kind of sometimes go down that winding, meandering road to find the best way for them, because it isn't always a straight path, and it isn't always as easy to determine, because as I think we've kind of really hammered that point home. Everybody is different in both sense of the word, everybody,
Yeah. Everybody.
So I think that's a good point to kind of maybe end on. I know you've got classes in about 15 minutes, John, so I'd let you give you some time to prep for that. But really appreciate it. I think this was really good talk, really helpful for anybody who is dealing with patients who've had kind of surgical issues or even non-surgical issues, which is pretty much everyone. It's a really interesting point that Dave and I found when we first started AMN and we first started doing live courses and live workshops, and we were talking to primarily personal trainers back in those days, because we were doing movement-based stuff in the early days. One of the very common themes was that people got into it because they started out personal training doing fitness related stuff, like exercise and health stuff. And they would get clients that would come to them and be like, this hurts, I can't do this, I've got this restriction here. And they're like, I'm not equipped to deal with this. And they're having to refer people out and stuff. So I think, this kind of information is really useful to have, whether it's surgical or non-surgical stuff that you're dealing with, and whether you're a physical therapist or an exercise professional, because it's obviously there's different scopes that people can be working within. But it is really important to know for fitness professionals as well.
That's a good point. I mean, as a fitness professional, you get a client that comes in and maybe they just have, an ache or something that's a little bit more than others. I don't think it's a situation you have to immediately be like, we'll go see this therapist right now, so it's checked out and make sure everything there. You don't have to be that overly cautious. I think you can work within those limits, and programs like AMN, especially, really helpful in helping fitness professionals manage that a little bit more clearly. I think that just goes to your confidence as a practitioner, and understanding your scope really comes into play with that too. I don't think it's wrong to send somebody out, but then you run into, from a business perspective, is like, hey, I'm going to lose that client for a little while.
Yeah.
What can I do to kind of manage it? I thought about this is, did they lose confidence in me because I didn't know how to help them with that situation? So there's a lot of factors to come into play with that.
Yeah, absolutely. All right, John, thanks very much for your time. And if anyone wants to find you, what's the best place to? Instagram?
The best place is Instagram, because
Yeah.
that's the only one that I prefer to use, because I use it a lot. I do, but social media is not my thing really. But Instagram, anyways, you should cut that part. It's at Dr. John Campione. So DrJohnCampione. I'm always up for a discussion. Trolling will get backlash. So.
Great. And I'll put that, I'll put your Instagram link in the show notes as well. So thanks, John. Appreciate your time. And thanks to everyone for listening.
Thank you guys. I appreciate the time.